Good day, everyone, and welcome to the webinar, Setting Up Comprehensive Care, Key Principles, Services, and Roles. This is the first webinar in the Path to Access to Care and Treatment, PACT Comprehensive Care Series, which has been designed by the World Federation of Hemophilia to support healthcare providers in setting up and strengthening comprehensive care at their centers. My name is Alok Srivastav, and I'm a hematologist working at Medical College, Vellore in India. It's been my privilege to work with the World Federation for many years, and I'm delighted to chair this meeting today, which over the next 90 minutes will look at presentations on delivery of care, which will then be followed by some polling questions, allowing the audience to give their inputs into the discussion points today, following which we will have a presentation on the key components of comprehensive care, and then a presentation on setting up a hemophilia treatment center, a comprehensive care center in one of the participating countries, as well as a discussion on the minimum requirements to establish hemophilia care. Throughout this webinar, we would like this to be as interactive as possible. And so there will be ample opportunities for discussion, question, answers, and comments. We encourage you to use the system, which will explain in further detail very soon, so how you can post your questions and take part in the discussion. Now, it's my great pleasure and privilege to introduce the speakers for today. The first speaker you'll listen to after me is Dr. Kate Kerr, who is an advocate of the nurse's role in a multidisciplinary team in hemophilia. She is the former chair of the WFH Nurses Committee and a founding trustee of HemNet, a hemophilia education and research company, and is now the director of research as well as the editor-in-chief of the Journal of Hemophilia Practice. Dr. Kerr used to work at the Great Ormond Street Hospital for Children, and then also she moved to the Center for Outcomes Research Experience in Children's Health, Illness, and Disability, ORCID, where she spent a good part of her academic career. The next speaker is Dr. Teresa Nwaga. She's a consultant hematologist in the Department of Hematology and Immunology at the UNTH Ituku Ozala Enugu and director coordinator of the Hemophilia Treatment Center at the same institute. She's also the vice president medical of the Hemophilia Foundation of Nigeria. She speaks frequently on thrombosis and hemostasis and has mentored and supervised many trainees in this area. She's also interested in sickle cell disease, a very important condition in her country. And the final speaker in our program today is Dr. Adolfina Burgess Garcia. She is a medical doctor specialized in pediatrics and pediatric hematology at the Children's National Hospital in Mexico, Dr. Federica Gomez. She has participated in the academic training of multiple generations of hematologists through Mexico, as well as academic forums, both at the national and international level. She currently serves as the medical advisor to the Federation of Hemophilia in Mexico. Welcome, all three speakers, and thank you for being a part of the program today. Now, we move on to some descriptions and instructions regarding how this program will work. So as I mentioned earlier, it's meant to be interactive. And the most important aspect of that is that we have at least 4 translations. So you need to choose which translation you prefer. We have French, Spanish, Russian, and Arabic. So when you click on the icon showing a globe, says interpretation, you will have the option of selecting the language that you want. It's written in those statements are written in those languages. So English is the default, but you can go to selecting either French, Spanish, Arabic, or Russian. Now, what you see in the next slide is if you're joining by a mobile phone, there are additional steps that you need to take. The image on the left shows an Android phone. Click on the three dots to select the interpretation channel. The image that is in the center shows an iPhone. Select the language interpretation option, pick the language, and make sure you click Done on the right corner of your screen. You should note that if you don't click the Done button, then your language selection will not be saved. So please do that. Now, in the next slide, what you see that how to ask your questions or make comments. There's a Q&A box icon at the bottom of your screen to submit your questions. We will, of course, try to answer as many questions as possible during the question, answer, and discussion time. In case we miss out any, there's always the opportunity to communicate by email later on. Now, after that, what you see on your screen will be the presentations. So to begin this webinar, let me start my presentation on the delivery of hemophilia care. Now, with respect to hemophilia care, there are two aspects. One is to define the long-term goals, some of which may remain aspirational at any point in time, and the other is actually organizing care within the existing resources. And we will discuss this in the next slide, which shows the attempt made in the latest edition of the guidelines for the management of hemophilia from the World Federation of Hemophilia. Now, this was a major effort over a long period of time, and what this slide shows you are the primary authors of this document. But it's important that we recognize that many more healthcare professionals, as well as professional staff from the World Federation and other agencies participated in making this possible. I'd like to acknowledge at least two people from among the authors, especially the two vice president medicals who spanned this duration of preparation of this document, Dr. Marika Vandenberg, as well as Dr. Glenn Pierce. And from among the WFH staff, it's very important to mention Donna Coffin, who put in a lot of effort coordinating this whole program. Now, with that, we have the document ready in the next slide, which shows you the 12 sections that exist in the third edition. The ones marked in pink are the new additions to the guidelines from the second edition. Now, among them, there are a few very important ones for day-to-day management, and those have been shown as with a tick. We will, of course, in today's discussion, be concentrating on the first two chapters. I will discuss the first one, and Dr. Kate Kerr will emphasize the next one. Now, compared to the second edition, which had about 140 odd recommendations, you can see that this has been enhanced with more than 330 recommendations in the third edition. In the next slide, what you see is the concept of defining principles of hemophilia care. So I want to get back into history a little bit, which tells us that about 13 years ago in 2008, a group of hemophilia treaters in Europe got together, calling themselves the Interdisciplinary Working Group, and put together what they call the European Principles of Hemophilia Care. They defined what every center, every country should try to achieve. As you can imagine, this was not easy to implement almost anywhere. So 5 years later, they came back and did a survey on behalf of then the European Hemophilia Therapy Standardization Board. And what they found was actually many centers were not able to complete all the requirements of the principles of care, and those then remained aspirational, something to pursue. Now, about 10 years after the Europeans defined the principles of care, a group of us got together in the Asia Pacific region and put together our own document, given the socioeconomic diversity, the different healthcare environment, as well as the cultural situation. And what the next slide will show you is a comparison of the two documents. The 10 principles that were defined in the European principles of hemophilia care were certainly included in the Asian principles of hemophilia care as well, though realigned a little bit to make it easier to read and understand. What we also did, which is shown in the next slide, is to add certain newer elements. Now, one of the challenges in the Asia Pacific region, as well as several other regions of the world, including Africa and South America, is the lower diagnostic rate among people with bleeding disorders, hemophilia included. Now, this was something, therefore, which was not considered so significant perhaps in the European region, but establishing laboratory diagnosis, ensuring that people with hemophilia and other inherited bleeding disorders get diagnosed was an important principle for us. Included in that also is now the opportunity of using genetic methods for establishing diagnosis. Given the inadequate therapy available to these patients, musculoskeletal problems form a major aspect of the management of these patients in this part of the world, and therefore we included a specific section in the principles on establishing both the management of musculoskeletal complications and also the assessment of their outcomes. So assessing outcomes also became an important principle. And then finally, having done these principles 10 years after the European document, we had the opportunity to talk about the newer products as well as the potential cure for hemophilia, which should remain the final goal for all centers all over the world. And then, of course, we had to mention that everything that we do in healthcare has to be within the socioeconomic and cultural diversity and the situation in that country. So based on those two documents, the European and the Asia Pacific, it really helped the World Federation in the next slide in putting together the principles of care for hemophilia in the world. And here what we did was to divide these 12 principles into two sections. The first 5, shown in bolder font here, refer to the organization of care for all people with hemophilia in a country, more from the overall structure of the program, its coordination, access to procuring and distributing products, the diagnostic as well as therapeutic services, and the education and training required to maintain the care that's being established, and of course, relevant research. And then the next 7 principles enunciated here refer to the care of the individual at the level of the treatment center, which may be a comprehensive center or hemophilia treatment center that provides more basic care. Now, we move to the next slide, which shows you that establishing a treatment center may seem very natural or easy for those who are involved in this field and are familiar with the management of hemophilia. But imagine a situation where a group of patients have come together, established an organization of their own for advocacy and support, and then they approach either a medical institution or the Ministry of Health, who understands their problem and agrees to establish care centers, a treatment center at a basic level or a more advanced center as a comprehensive care center. Now, what we found is that many times people are not sure what exactly to establish in these places, what facilities, what personnel, what equipment. So what was done here was to list out the kind of services and people required to provide them that needs to be established to call a particular center a hemophilia treatment center or something more advanced as a comprehensive care center. So this busy slide is not for you to read, but to know that such a definition now exists within the guidelines of the World Federation of Hemophilia, which can be used both for advocacy in the beginning and after that as a checklist for quality. Now, an important point to mention here is that there are different models of establishing such centers. In some places, what I've seen in India is that within an existing hospital, people try to designate a special area, maybe a new building or a few rooms, where you put a board saying Hemophilia Treatment Center or Hemophilia Comprehensive Care Center. And then within that, you have a reception area, a room for consultation with the patient, maybe a room for physiotherapy, maybe a few daycare beds, and also a laboratory in some cases. So that's one model. The other model, of course, is where you establish these services within the existing departments and facilities. And more than designating physical areas, you designate individuals and train them in providing care for people with bleeding disorders and hemophilia particularly. Now, that's a more integrated model, and I must say that my bias is for the latter. You know, our institution has been providing care for people with hemophilia for more than 50 years. If you enter this 2,500 bed hospital, you won't find a board saying Hemophilia Treatment Center, because the entire hospital in a way is a hemophilia treatment center in case such a patient requires any specialty service. So I think it's important to recognize that there are different models and you can choose whichever works better for you. Now, in the next slide, what you find are a very special feature in the principles of care that was included in this section in the third edition of the management guidelines. This is patient empowerment. Now, one cannot overemphasize the need and importance of informing and educating patients about their condition, what it is, how does it happen, and how should it be managed. It's not enough for their physicians and healthcare providers to know that alone. It's very important that these patients learn to recognize bleeding. They learn to keep records of bleeding and the treatment. We know that this is important not only for those who participate in clinical trials, but also people for their own follow-up at their centers to know how many bleeds they had, how many sites at which this bleeding have occurred, and what treatment was provided for them. How did they respond to the treatment? Are they administering the clotting factor constraints or the hemostatic products themselves? And how do they manage that? What about pain management? Other risk factors for bleeding, how do they avoid those? And finally, they are the best people to report on certain outcomes. What is their bleed rate? What is their pain situation? What is their ability to take care of themselves in terms of activities of daily living or extended social participation? So participating in the reporting program is also very, very critical to establish good care. All of these also then provide some guidance to the advocacy organizations regarding what they should emphasize in their own programs with their members. So this is a very special feature of the program and this section in the treatment guidelines. The next one. This really is my last slide, which provides the segue for the next presentation on the details of comprehensive care. I have mentioned this here for two reasons. One, depending on the complexity of the complications that happen in these patients, starting with a hematological bleeding disorder, then if they bleed in their joints or muscle, you require musculoskeletal specialists. If there are other complications, you may require surgeons. And then depending on what else happens, or if there is an issue of prevention, carrier detection, then you require the geneticists. Now, the important issue here to recognize is that almost all of the healthcare providers, the professionals listed here, provide part-time service to people with hemophilia. The one person in the team who's usually full-time is the nurse coordinator, the nurse consultant, or the nurse coordinator. And this is important to understand and plan for in organizing a comprehensive care center, because this person is critical in making first contact with the patient, understanding what their need is, and directing them to the right people. The second aspect here is, moving from providing care to actually providing surgical treatment if needed is a major step forward. And doing surgery for people with bleeding disorders requires coordination between the laboratory and the clinical services. But doing surgery for people with inhibitors is something that is a major challenge for any center, however well established they may be. So I think it's a kind of a benchmark. When you first start hemophilia treatment, you establish a comprehensive care team. You then learn to offer surgery for those who need it. And then being able to offer surgery for people with inhibitors, is of course a major advance. Now, the final point I wanted to make here was, we have all emphasized the need and importance of comprehensive care, but it must be called for what it is. In some ways, it is the failure of adequate management of these patients that lead to the complications, where one set of physicians or their team was not enough, and you then had to bring in several others from the hospital system. So hopefully going forward with better management and indeed cure of this condition, we may have a very different look of this comprehensive care team in the years to come. And with that, I will stop and thank you for your attention. Now, before we actually go on to the Q&A session, we have two next steps. The first step is a set of 5 questions that will be put to you, and over about 30 seconds, you will need to answer these questions. This will give you and the rest of the audience, and of course, all the speakers and the panelists, an idea of who are we, who are all participating in the program today, and what is the situation on the ground with their centers. After we finish that, we will have the presentation from Dr. Kate Kerr, following which we will have discussion. So we will start with the first polling question, which asks, is your hemophilia treatment center a standalone unit separate from a hospital? Is it physically separate within a hospital, or is it integrated within the existing facilities in a hospital? Or do you have any other model? And I think your time starts now. So it looks like there is no music. So we will have about 30 seconds to see your answers. You can see a window that has come up. It should be active if you take your cursor and make the choice that is most appropriate for your center. We will have the results showing very soon. Okay, I'm sure somebody is timing this. Yeah, we are done. Okay, so that's what we have. We have all combinations, and that's important to know that about a quarter standalone units, physically separate, but good to see that about 2/3 are part of the existing hospital facilities. We'll come back to this. The next polling question is about shall we move to the next polling question, please? Yeah, thank you. Which core members of the multidisciplinary team work at your center? And here, of course, you can choose all that apply. Okay, we just want to get a feel of how the centers from which people are participating today in the meeting have organized their own services. So you could have a physician with interest in hematology or bleeding disorders, a pediatrician with interest in hematology or bleeding disorders, or a trained hematologist. You could have a nurse coordinator dedicated to this service. You may have physical therapists. You may have laboratory specialists, both at the technical and the physician level. And then you may have orthopedic surgeons or other musculoskeletal specialists, such as rheumatologists or specialists who are called physical medicine and rehabilitation specialists. And then, of course, you may have psychosocial support through social workers or psychologists as counselors. So, okay, we're getting faster with the answers. We have about 64 people participating. So yeah, okay. Nothing to comment. And as expected, maybe about half this, or 1/3 of the centers have psychosocial support. This is usually an area that's less. I am surprised to see that MSK support is only in about 40% of the centers. In countries where treatment is not very uh, early and intense, often these complications are more. So we will come back to these comments, right? Okay, the third polling question is about how is the service organized at your center? Is it only as outpatients, or do you, as in an outpatient clinic, or are you able to have some daycare admissions, or you have, regular inpatient admissions for several days if needed, or is there some other mechanism of providing service? This could be outreach, including home services, if you have them. So please make your choice now. You could choose more than one, obviously. Okay, so interesting. So the people who are participating today, about 60% have daycare and inpatient. Of course, everybody provides, almost everybody, 90% plus, provide outpatient care. Okay, let's move to the fourth polling question, which talks about surgery. As I mentioned earlier, a significant advance at any treatment center is to be able to provide surgery for people with bleeding disorders. So of course, you may not be providing that at all. If you provide that, is it only for minor or major as well? Is it for people with bleeding disorders without inhibitors, or any patient with bleeding disorder? You can choose from among the four options. Between the latter two, it's a question of the sophistication of the hemostasis laboratory and the hematology clinical team on handling the products for managing people with inhibitors for surgery. That's a major challenge anywhere in the world. Okay, so good to see that only about 17% do not provide surgical treatment. So we are dealing today with centers that are well established, providing surgery, at least 50%. We then have with inhibitors in about 40%. So about a quarter without inhibitors and about 40% with inhibitors. We will make note of that and we'll come back to these answers during the discussion. Thank you. And the last question for today is, in case you are having some challenges establishing comprehensive care the way we have discussed it so far, but a much more detailed presentation is just coming up. And I'm sure your answers will be commented upon during the discussion and the presentations. What are these challenges? Is it the lack of therapeutic products? Is it the lack of specialists? And then there is a situation where in the multi-specialty hospital, you have specialists, but they have never dealt with people with bleeding disorders, and they're just inhibited from providing the services that they could provide if only they had training. So when I say lack of trained specialists, it's lack of training in managing people with bleeding disorders with those complications. And then is it that you do not have suitable laboratory support for procedures to be performed, or are there other reasons why comprehensive care is not complete at your center? You can vote, please. Okay, so it's a range of issues. It's interesting to see that nearly 60% of centers participating today have mentioned lack of trained specialists. This is something I'm sure the World Federation will take note of, because training is a major component of the programs of the World Federation. Uh, Suitable laboratory support, again, a matter of training. Lack of therapeutic products. I mean, that's again a very important one. The humanitarian aid program helps there, but of course, local self-sufficiency is always an important component of that. So we'll come back to this. So I think we have completed the polling questions. I think we have time now to engage our panelists, who will now comment on these polling question answers first, before we go on to the program, the presentation from Dr. Kate Kerr. I invite Dr. Kate Kerr to comment on, or maybe I'll give her, I'll request her to comment last, and then she can go on directly to the presentation. Let me start with Dr. Teresa from Nigeria. Your comments, please, Dr. Teresa, on the responses you saw so far in the polling questions. Thank you.
Thank you, Dr. Alok, and thank you, WFH PACT program for the opportunity. While looking at the polling questions, especially for question number 1, I found that most people answered that the part of their HTCs are part of existing facilities within their hospitals. This particular type of model for hemophilia treatment centers are what you have, say, around most institutions in Africa and maybe some LMICs. I don't know how it's obtainable in other parts of the world, where the model of co-opting other specialists who are interested in the management of persons with hemophilia and other bleeding disorders are the norm. In my center, we don't have a standalone center. Well, what we have is rather individuals that have been co-opted into the team. And that reflects the majority of what the participants answered. There are some people that answered that their HTCs are part of a standalone center, or that they are all units too. Those are equally important. But the option of having facilities within an existing hospital seems to be the commonest type of model for HTCs among the participants. Thank you.
Thank you, Dr. Teresa. I request those who are not speaking to mute themselves, so we do not have any screening sounds. I'll now request Dr. Adolfina Garcia to make her comments, please, on the answers from the polling questions.
Dr. Adolfina was mentioning that in Mexico there's the access to proper specialists or multidisciplinary care teams, but not always they are in the same building or in the same place. So what they have is they request from other places or from outside the hospital, the specialists that could provide this opinion, and then they can, in the end, have this multidisciplinary care, even if the professionals are not all in the same, let's say, in the same building or in the same hospital, so they can manage to provide better care for the patients. Yeah.
Thank you. Is there any other comment, Dr. Adolfina? You were saying something when I think have you completed?
Okay, so Dr. Adolfina mentions that that it is important for the patients to have access to this multidisciplinary care team in second and third tier or third level hospitals as they are organized in Mexico. But it is also very important, and that's something that they've been working on, to have access to emergency care available 24/7. So whenever the patient has a breakthrough bleeding, he can get this patient can get access to treatment and can be treated.
Thank you, Dr. Adolfina. It's now my turn to invite Dr. Kate to first comment on the polling question answers and then go on to her presentation. Thank you, Kate.
Thank you, Alok. So I think very interesting to see how many people already have what is at least the basics and the beginnings of a comprehensive care team with multidisciplinary care team members. And I'm delighted to see that 77 say they have nurses. And thank you, Alok, for saying how important nurses are in the haemophilia team, because of course I would say that. So I'm glad to hear that coming from somebody else. And then the other thing that I was slightly concerned about, and perhaps what we're doing today will help, is that only 61 reported that they had specialists who were trained in managing people with bleeding disorders. And so I think the work that we're doing here with the WFH, and hopefully when the WFH can start coming back out into countries to deliver local training, that will improve. I very much hope that happens.
Thank you, Kate. So your presentation now. Thank you.
Here we go.
Hello, I'm Kate Kerr. I'm the Director of Research at HemNet. I also work in the Centre for Outcomes and Experience Research in Children's Health and Illness and Disability at Great Ormond Street Hospital for Children in London, and I'm the past chair of the WFH Nurses Committee. And I'd like to thank the WFH for inviting me to speak today about the key components in comprehensive care. These are my disclosures. So most of what I'm going to say today is based on the publication of Chapter 2 of Comprehensive Care in Haemophilia from the new WFH treatment guidelines, which were published last year. So please do go and look at those, but I will be adding in some different things along the way. Comprehensive care is a multidisciplinary care, and it is primarily for the diagnosis, treatment, and management of bleeding disorders, not just haemophilia, but all bleeding disorders, including the complications of the conditions themselves and the treatment that we may give. It is usually, but not always, delivered by a treatment centre, and that may be small, it may be large, and it's usually a team of people that deliver and or coordinate care for 24 hours of the day. That doesn't mean you do it all yourself 24 hours a day, but you might be liaising with somebody in a different hospital or somewhere close to a patient at home to enable them to be able to get their care when they need it. And the focus of comprehensive care is not just on the person with the bleeding disorder, but also on the family of that affected person. And that focus should be both physical and psychological, and look at the health and well-being of the whole family, including, and I'm putting carriers here in inverted commas, because I think we should now be calling these ladies women with haemophilia. I think we should be really aware of them and make sure that we include them in the care of their child or their family member, and don't ignore them because we don't think that they bleed too. So what does comprehensive care do? And I'm going to say this a few times over the next few minutes because it's really important to recognise that we all do things slightly differently, and there is no right or wrong way for any of this. Whatever you're already doing will be really good, and hopefully it'll improve over time. So importantly, comprehensive care is about diagnosis. So we can look at a person or a child and say, we think this child has got haemophilia, but we can't say we think he's got haemophilia A or haemophilia B from the clinical presentation. So we need a laboratory that can help to diagnose the condition itself. Really importantly, what we do most in comprehensive care is to think about treating people with bleeding disorders, either when they just bleed, or if they have a condition where you can give prophylaxis, to give prophylaxis. And that might include home treatment. And that might also include trials of new products that are in clinical trials that are coming to your countries and to centres near you soon. I said earlier, we need to think about the side effects of treatment. So monitoring the treatment that we're giving at the time of surgery, making sure we've got good levels, but also thinking about the sort of softer aspects of living with a bleeding disorder, including pain management, not just in the acute bleeding phase, but later on when patients have arthropathy, and also quality of life. And as I said earlier, not just of the person that is affected, but also the impact on the family. And most of that is done through education and research. And that is about local care delivery. So the patients that you're looking after may live many, many miles or many hours away from your centre. And so that's about ensuring that they can get treatment closer to home, which might include home treatment itself. But also importantly, encouraging them and or the local hospitals or care providers to record the treatment that they're giving and the reason why they're giving it, so that we have really good data collection. So if we think again about what a comprehensive care centre is, it should be somebody or somewhere that can provide care for 24 hours a day, including a coagulation laboratory that might or might not be able to assay factor 8 or factor 9 levels 24 hours a day. And even in very large centres in Europe, many can't do that out of hours at night or at weekends and bank holidays. So don't beat yourself up if you can't do that just yet. What you should, though, have is the clotting factor concentrates in your centre, and those could be plasma-derived or recombinant, or treatment for people with inhibitors, or desmopressin, and antifibrinolytic therapy. And that may be held in your haemophilia centre itself, it may be in the pharmacy, or it may be in the blood transfusion laboratory. And that will depend very much on the rules of the countries that you are in and your local policies. You should also have access to blood products such as FFP, cryoprecipitate, and platelets for people who are treated with non-factor concentrates, where there isn't a concentrate available to treat them. And those products should be screened and tested and virally inactivated for the safety of infusion and the safety of the patient. Ideally, you have a physiotherapist who is part of your team, and we'll talk about this a little bit later. But it may be that you only have access to a physiotherapist, and that person should be able to provide casting and splinting, rehabilitation, using price, but also thinking about aids for crutches, walking, and mobility. And then you should have access to other specialists, and we'll talk much more about those a little bit later on. So who is in your team right now? So you will have, and I've put them front and foremost here, people with bleeding disorders and their families. They are a very important part of the team. Without them, we wouldn't have a job. With them, we have a really interesting job, and our job is in supporting and educating them, and we'll talk more about that later, into the condition that they have and how to treat it. And then the next person in the team, I've called a clinician, and that is deliberate. It isn't a physician. It might be a physician, but it doesn't have to be. So it may be that the clinician is a nurse or a physiotherapist or a social worker or somebody who is coordinating the team and starting to engage with patients and their families about living with their condition, and building and delivering the team that you're going to hopefully have as you go forwards. And then once you have your people with bleeding disorders and your clinician, you need a core team. And these people here are the people who ideally are in your core team. And again, I want you to not think that you can't have a haemophilia team or deliver comprehensive care because you don't have all of these people. So when I think back to when I started as a haemophilia nurse a long, long time ago, there was me, I was full-time. There was a physician who mostly did leukemia, and he did haemophilia 1 day a week. And we had laboratory staff, and that was it. We now have a team who include all of these people. And you will see this slide again in a couple of slides' time, and we'll talk about how you move from where you are now into building a better team. So the core multidisciplinary team are the centre director, the nurse coordinator, and the WFH guidelines talk about the importance of nurse coordinators 13 times. So for all of the nurses out there, you are the most important member of the team. A physiotherapist, psychosocial support, and laboratory staff. And you can see that usually the centre director is a doctor, and that's most commonly a paediatric or an adult haematologist. But not always. There are some nurses who are centre directors, and they would oversee the laboratory testing, prescribing treatment, although again, that's something that many nurses can do, and monitoring outcomes. The nurse coordinator coordinates the provision of care by the whole multidisciplinary team. We're very much the person who pulls everything together. And we educate patients and families and others, so local healthcare providers, local schools, places where people work, maybe churches, depending on where you are in the world, they might be very important for your patient. We're able to assess patients when they come in with bleeding, initiate care, and coordinate that care at home. The physiotherapist is really another very important member of the team because they can educate patients and caregivers on bleed prevention and then rehabilitation to ensure functional recovery once a bleed has occurred. And then living with haemophilia or another bleeding disorder and the impact it has on the person and their family does cause psychological distress. And so having some kind of psychosocial support, be it a social worker or a psychologist, that provides care as part of your team or provides and supports patients being assessed and supported locally is really important. And increasingly, we are using psychologists and social workers to do more formal psychological assessment to look at quality of life, burden of treatment, and improving the care that we're able to give as we move forward. And then the laboratory staff are also really important. They might be in a different bit of a hospital or even a different hospital or different facility altogether. But you need to have a really close working relationship with them because we want them to be able to do that factor 8 level when we've got the newly diagnosed patient in front of us. And we'd really like that today, not in 3 weeks' time. And so having that great relationship so that they can be part of the team and feel that they are part of the team is really important too. So I showed you this slide just a couple of slides ago and said that these are the core team members and that hopefully you can see your haemophilia comprehensive care team is already forming as part of who are here already. But as things change and as your team becomes more extended, you may end up with an extended haemophilia team that looks something more like this. So still right in the middle, in the sort of darker green, we've got the patient and his family or her family. Then in the sort of turquoisey colour, we've got the core team. And then as your service develops, you will need to get more people. So it might be that suddenly you're able to start doing genetic testing. And for that, you might need a genetics laboratory or a geneticist or a genetic counsellor. You might suddenly be able to offer patients gene therapy. So you might have gene therapists or immunologists or hepatologists being involved in that care. Your factor might start being delivered to patients at home, and so that might need pharmacy involvement if you don't have that already. You might have a home care service, perhaps a nurse or somebody in the community that is supporting patients at home. As people with bleeding disorders get older, we're certainly seeing people going into long-term care homes as they're elderly, and that is a whole new area for all of us to be working in. And there's more work with the pharmaceutical companies as new products are coming on board and there's clinical trials. And all of that is underpinned by data. Data is increasingly important in showing that the care that we give is effective and safe and that it is of benefit to the patients. So here are some of the recommendations from Chapter 2 of the WFH report from last year, looking at the main functions of comprehensive care. And here the WFH recommends a multidisciplinary checkup, so talking about having the team seeing the patient, not just one person. That includes haematology, so your blood tests, your physiotherapy, doing some kind of musculoskeletal assessment, and quality of life assessments. And that should be done yearly and maybe every 6 months for children. Just to focus here on quality of life, that does not mean you've got to do a formal quality of life assessment using a validated questionnaire. That's about talking to family and people with bleeding disorders about how they're coping, how is life, what can we be doing to make things better for you. And this says children and adolescents with haemophilia should be supported with ongoing education and skills development. But for those of you in countries where you're diagnosing adults, particularly adults with haemophilia for the first time ever, it's about teaching them as well, about self-infusion, but also other self-efficacy skills. So thinking about self-management in a broader term than just giving factor. And that is all about care coordination. So thinking about within your multidisciplinary team, what is the right time or stage for this young person or adult to be being educated around how they got their bleeding disorder, what it means for them, and how it's going to be in the future. And we do that by working as teams, both as an inpatient when patients perhaps come in for bleed management or surgery, but also in outpatients when we're following them up after a bleed. We've already talked a little bit about treatment monitoring and the annual review, but also to think about when patients are having surgery, how we're monitoring the treatment that they're having. And that means to have surgery. I haven't yet come across a haematologist who thinks it's okay to take a scalpel to somebody himself. We are referring on to the appropriate surgeons. And all of that is done by working with the patient and the family. So we need to think about individualised care plans for each individual person that we're looking after. And we should be auditing those at the annual review and refining them as things change. Most importantly, I think if you think about a patient with being diagnosed with haemophilia today, he could be being looked after by a haematologist anywhere or a nurse somewhere. And the thing that's really key for a comprehensive care service is bringing all of that together and getting the experience of having a few patients or lots of patients with haemophilia or other bleeding disorders, and then supporting the patient and his family through education and support. That's really the whole ethos of comprehensive care. And if we're able to do that, we can better improve the care that we're giving, but also the outcomes for the individual and for all of the people that we're looking after. And so we should be working alongside other people who are in the haemophilia team that we're in, and others locally if you have more close by to where you are, but also working very closely with patient organisations and thinking about how we can work together to better the interests and capabilities of us, the patient organisation, and obviously for the whole haemophilia community. So in conclusion, multidisciplinary teams promote the best care and outcomes for people with bleeding disorders. That has been proven time and time again. And that's because we're able to educate and support affected individuals and their families. But that team could be very different wherever you are in the world, as long as we're all in some cohesive way improving the care that we're giving and working together on making sure that that happens. We can only do that if we really engage with people with haemophilia or bleeding disorders and their families. They're, as I said right at the very beginning, one of the most important members of the haemophilia team, and we really need to ensure that we are individualising age-appropriate care for each and every person in the family who is affected in whatever way. And the best way to do that is by educating and supporting the person to be able to self-manage. So thinking about bleed prevention, bleed treatment, and how they live well in their lives. I'd like to thank you for listening, and please do ask any questions.
Thank you, Kate. We will now move on to the next presentation. And it's my pleasure to introduce Dr. Teresa Nwaga to discuss the key setting up of comprehensive care in Nigeria. Tessie, over to you. Thank you.
Thank you, Dr. Alok. Next slide, please. I would like to thank the World Federation for Hemophilia for inviting me to speak about setting up Hemophilia Treatment Comprehensive Care Center in Nigeria. And my discussion will go with this outline. Next slide, please. So a bit of a background. It's estimated that we have over 21,000 persons with hemophilia in Nigeria. That's based on the current global prevalence rate of 21 per 1,000 persons for a global prevalence rate of 21 per 1,000 persons. So currently, we have identified over 600 persons with hemophilia in Nigeria, and hemophilia management as a whole has really evolved. From the first time the first Nigerian was diagnosed with hemophilia in 1967 till 2001, when we've started receiving donations of emicizumab from the World Federation of Hemophilia humanitarian aid program. We have gone from areas of when our consumption rate was 0 IU per capita till when we started receiving the humanitarian aid program in 2015. Until date, we have received over 22.7 million IUs from that humanitarian aid program. Next slide, please. Next slide. All right, I'm not going to go into this slide, as Dr. Kerr has really exhaustively spoken about hemophilia treatment centers and comprehensive care of hemophilia. So what you would know is that hemophilia care has evolved and is still evolving. And HTCs, as was rightly, said by Dr. Kerr, have been recognized as significant drivers for standard care for persons with hemophilia. In Nigeria, we have evolved from hematology clinics as places where care is given to persons with hemophilia to establish hemophilia treatment center. So in Nigeria today, we have 13 hemophilia treatment centers, of which 6 offer comprehensive care. Next slide, please. So what has hemophilia management as a whole been before establishment of hemophilia treatment centers? What our experience had been is that we had new support from management. When I mean management, hospital management, there was paucity of persons with hemophilia and other bleeding disorders in the hospital, to the extent that clinicians were doubting if hemophilia was really a problem in our locality. There was non-existent of multidisciplinary team. Care was not coordinated or proactive. There was absence or limited access to coagulation factor concentrate. And most importantly, there was lack of confidence of persons with hemophilia. They generally did not believe that or trust their doctors knew what they are doing as far as their management was concerned. And because of that, and also because of traditional beliefs, they refused the coagulation factor products even when it was available. So the management before establishment of HTCs in my own center saw just only 2 registered patients. As I said, the multidisciplinary care team was absent. The coagulation factor products were not at the hospitals at that point in time. And the patient outcome was not favorable. They either died from the disease condition or were lost to follow-up. Next slide, please. So based on this experience, we were able to identify some key components that we felt would be important in establishing our hemophilia treatment center. And one of these components range from support from our national member organization, in this case, Hemophilia Foundation of Nigeria, getting the buy-in of our hospital's administration, and also forming our patient-centered multidisciplinary core team. Just like Dr. Kerr mentioned, the composition of these teams differ from center to center. But what is common and what people should look out is that you should form a team that the team members are dedicated, committed, and they have this ability to work together as a team. Again, is the physical structure of having a hemophilia treatment center. It's important, but it's not a priority. What we have in our center was us forming a HTC from already existing structures and then reaching out to interested specialists from other departments who have interest in management of persons with hemophilia to come on board the team. And another important component is building up confidence and trust of persons with hemophilia. Next slide, please. Next slide. So initially when we started, our Hemophilia Treatment Center was established in 2012. And at that point in time, we just offered the basic care, which includes running outpatient clinic, doing physical therapy, and then laboratory services. But as we built on the confidence of our persons with hemophilia, they started reporting to the hospitals, and soon there was need for us to have a hemophilia nurse. There was need for us to have a pharmacy that was dedicated to dispensing the coagulation factor concentrates. We had dental surgeons, orthopedic surgeons, neurosurgeons, pediatric surgeons, and the genetic counselor and social welfare. Unfortunately, in our centers, we've not been able to build capacity for genetic counselors and social welfare. Next slide, please. So these are our wins. Since we established the treatment center in 2012, we have had the commitment and the buy-in of the hospital administration. We were able to restore the confidence of persons with hemophilia and their families, and we were able to build up an outpatient registry with the help of the WBDR. Now our patient base is at 62. Hemophilia care was now specialized, coordinated, and proactive. And we got help in expanding our services. We were involved in the WFH training program. Some of our healthcare practitioners went on to for the IHTC fellowship, and just like I mentioned before, we were immensely supported by our NMO. Equally, we also increased awareness through training of healthcare practitioners, public awareness through media advocacy and outreach. One thing that was an outcome of increasing awareness was that the healthcare practitioners within the hospital were now able to have a heightened sense of clinical suspicion, and the public became more aware about hemophilia, and we started getting referrals from clinicians and from other hospitals and persons, as it were. And again, we also expanded and we were supported by the WBDR research program. Again, as we are now, we don't have genetic counselors, and we don't have social welfare services. Because we now have a population of persons with hemophilia that are getting into their teenage and probably reaching ages where they want to have relationships. So our hematologists and nurses are doubling as counselors in this aspect. Next slide, please. Next slide. Okay, so this is our statistics, and basically the hemophilia A forms the highest percentage of bleeding disorders we have encountered in a hemophilia treatment center, with platelet disorders being at the lowest. The second graph, you could see that there has been a progressive increase in the number of patients with hemophilia attending care in our treatment center. And these are the surgical procedures that we're able to carry out in our HTCs. We're able to do dental procedures, both for pediatric and adult group. We've done chemical synovectomy, craniotomy, circumcisions, and other minor and major surgeries. Again, for our bleeding pattern, musculoskeletal bleeds form the majority of bleeds that we see, with the intracranial bleeds and organ bleeds having 2% and less than 1% respectively. Next slide, please. So for our coagulation factor concentrates, we are totally dependent on the WFH humanitarian aid program, and we get donated products, extended half-life products, plasma-derived, recombinant products, and recently we received donations of emicizumab for 14 of our patients with hemophilia. And I must, at this juncture, say that our government recently added hemophilia as one of the non-communicable disease groups in their platform. So hopefully, we would have them buying these products in the nearest future. Next slide, please. So these are some of our donated products being stored away in the fridges. Next slide, please. So what are our challenges? For our challenges, I would like to use a slide I prepared in 2017 to give you an idea where we were at that time and where we are now. So for our challenges, there were patient-related challenges, hospital-related and government-related challenges. Well, the poverty level is still low, and that also prevails on some of these patients accessing care because of the localization of the treatment center. Some of them have to come in from far distances and all. About the lack of awareness, this has remarkably improved among the healthcare professionals, the public, and as it were. We have also able to increase patient support groups and educators. We have heightened advocacy. Our patients are no longer afraid of stigmatization. We've also been able to establish research and patient registry. For our trained personnel, some of our healthcare practitioners, the members, benefited from the WFH training that was done locally and internationally. Likewise, we also got support for our laboratory, and we've been able to do some diagnostic workups in the hospital. And like I said, recently the government included hemophilia as one of the non-communicable diseases, and we are getting increased commitment and support from the government. And I have no doubt in the nearest future that the Nigerian government will soon start procuring factor concentrates for persons with hemophilia in Nigeria. Next slide, please. So this used to be our reality. We had a group of boys that have different stages of hemophilic arthropathy. Next slide, please.
Let's see if we can wrap up soon. Thank you.
Yes, most of them were coming with bleeds. And next slide. So this slide shows the cohort on low dose prophylaxis. Next slide, please. So this is a emicizumab program, and these are patients on emicizumab. And the next slide. So in conclusion, this is our engagement with our management, hospital management. Next slide. I would like to thank WFH NMO for our journey so far. We wouldn't have made it this far without their support. And I also want to conclude by this statement that was made by a 15-year-old patient of mine on a prophylaxis who remarked to his mother, "Mommy, I am now more normal than those with normal clotting factors." Thank you so much for listening.
Thank you, Tessie. That was a wonderful description of the journey in Nigeria in establishing hemophilia care. We move now to the last presentation in this program, and it's my great pleasure to introduce Dr. Adolfina Burgess Garcia from Mexico to talk about minimum requirements to establish a hemophilia clinic. Dr. Adolfina, please.
Good afternoon. It is my pleasure to be here presenting for the valuable work of the World Federation of Hemophilia. I will briefly discuss about the minimum requirements to establish a hemophilia clinic. I will be speaking on behalf of Mexico. I will be talking about how patients are managed at the Mexican Social Security Institute, the IMSS. It is the biggest agency, the one that has the greatest capacity to take care of hemophilia patients. It is distributed across the country. Mexico is a vast territory, and therefore there could be differences between different hospitals, even when they belonged to the IMSS. We know that patients living with hemophilia have a chronic condition that does not get cured. This has a high impact in connection to their economy and social life. So in order to provide a better response, we require a multidisciplinary team. This is known as comprehensive care. The role of the clinic is to provide patients with a comprehensive assessment and care. This will be determined based on institutions' individual decisions. But in pediatrics, it's every 6 to 12 months, and when it comes to adults, it's once every year. Treatment for patients with hemophilia, the best thing that can ever be offered to them is comprehensive treatment. This has been broadly been shown by the WHF, where they show that patients who are provided care in an institution will have a better reduction of morbidity and mortality. Here we see children who are on a camp. They are camping. And what we get to see is treatment being offered to them with coagulation concentrate factors with a comprehensive multidisciplinary care team. This will improve the quality of life. So comprehensive care will enhance quality of life, it will decrease morbidity, it promotes mental health, and it decreases mortality. How to integrate a hemophilia clinic? We sometimes do not have all the elements in place to say, I will have a comprehensive care facility. Nonetheless, if we have a hematologist, if we have the patient and the patient's family, surrounding patients, well, this will be enough for me to say, I will get started with my hemophilia clinic. And this could be referred to as comprehensive care. This can only be achieved with physicians that are having a buy-in in this process. This is a doctor who is not part of our hospital, but she does get referred patients to her own practice. Here we see all the members that we recommend that should be in place for us to be able to claim that we offer a truly comprehensive care. Nonetheless, it is not necessary to have everybody on board, as we will get to see later on. Nutrition, of course, it would be good to have nutrition experts, but if we do not have nutritionists, then physicians can always provide dietary advice to patients. As to genetics, well, this is for very special cases, psychology, odontology partially, orthopedics and rehab, those are outside from our area. This is my triangle. By now, it could also be a square. But I am a hematologist, and I started this hemophilia clinic with the support of social work. They were the ones who kept contact with patients. They offered training courses. They tried to teach patients how to get factors infused. Nurses, they teach hemophilia patients, patients' relatives, and their surrounding people anything that is related to the necessary care for these patients. Both teams support everything that is related to the comprehensive care, to prophylaxis and whatnot. And of course, the laboratory should be there in place for an accurate diagnosis, to know the type of hemophilia type, to know whether the child who is starting primary prophylaxis, who might not be responding, to see whether they have inhibitors. This is essential for us to have a hemophilia clinic. This will get us far. Of course, we always should seek for support from other specialists. How about the functions of a clinic? To provide and coordinate hospital and outpatient care with primary prophylaxis, there's a considerable reduction of hospital care. And of course, when it comes to outpatient care, they will only go when they need to get treatment. To train patients' relatives and relevant health personnel on emergencies, on intensive therapy, on laboratory techniques, what to do in the case of an emergency. This would be promoting timely treatment at home. Everything should be home-based, and patients should only go to the hospital for full assessment and decide what the diagnosis is. They always should be encouraged to go back home. Ideally speaking, all members should be at the same space. That would be a nice have. But if that is not possible, then each specialty can evaluate the patient separately in other hospital units. So what matters is that we should ask patients, adult patients, to come see us once yearly, and we have to ask children come see us every 6 months. Rehab will always be essential, and we will have them get assessed at the rehab hospital if that is the case. Hemophilia care, it must be specialized. All physicians should be trained in hemophilia. Additionally to hematologists, nurses, social workers, and laboratory experts, all other staff members should get some training. Orthopedic doctors should be trained in operating on patients with hemophilia. They should all have some sort of training in hemophilia. So when it comes to needs of patients and families, they are better met in comprehensive treatment facilities rather than by individual physicians. What matters here is to have a medical team that should be familiar and should have acquired expertise on hemophilia care because they will be serving those roles. What about the objectives of hemophilia care? First and foremost, to improve the quality of people with bleeding disorders. We do get to see that children run, they are happy, they go to school. There's no need for formal assessment, but we do get to see it in daily activities. They should enable collaboration between different treatment centers and care networks. All bleeding disorders have to be included, not just hemophilia, but other rare coagulation deficiencies, such as factor 7 or factor 5 deficiency, and to always assess outcomes. At least once yearly, we need to sit down and assess what results have been like, how many surgeries, how many physical checks, etc. We need to establish indicators to assess the quality of life and the quality of care. These indicators are globally used. That's the bleeding record. I guess it is called the annual bleeding rate. And that's a rate that would be really helpful for us to know whether the bleeding rate has come up or come down or whether it has been stable. This is a rate that we can always be using for our assessments. We also have to account for the amount of product that was used and under what situations and whether there was any deviation. This is really important because these are highly costly medications and we need to conduct oversight on them. And these care facilities have an obligation to participate in research, education, and innovation. If we do not publish our experiences, chances are that we won't get to be known by what we do. A commitment to educate patients and families, participants of hemophilia care centers, of comprehensive care facilities, should offer courses targeted to patients and families. Community courses can also be offered. Maybe at schools, people should go and talk about what hemophilia is all about. A member of our team can always be there to be in charge of these sessions and also to provide support to patient associations. We need to meet this goal in order to feel that we are part and parcel with the social environment where our patients are moving, and to find how this child will perform and how the child will interact in a number of different situations other than going to the doctor's office. In concluding, I should say that what matters the most is that hematologists should be open and willing to have and run a hemophilia care center, a hemophilia clinic. Hematologists will then call on board other practitioners, nurses, social workers that will like their job. They will make sure that there should be a 24-hour emergency service, that there's adequate treatment in sufficient quantity in place, the necessary quantity of factors or other molecules or bypassing agents in sufficient numbers, because the weekend may come along and maybe one single dose won't be enough. They should know how to manage every and all complications that might be presented by patients. The first impact should always be by the hematologist expert. Thank you so much for your attention. I will remain attentive to your questions, and I'd like to invite you to the next Worldwide Congress in May 2022, from May the 8th to the 11th in Montreal. Thank you so much.
Thank you, Dr. Delfina. I also wanted to take this opportunity to thank all the speakers for their presentations. And we now move on to the question and answer session. We do have time for, if the host can allow me to start the video. Yeah, thank you. So we will go now to the question and answer session, and there are quite a few that's been waiting for a while. So let me start with the first one that came in. This is from Megan at the Diran. Home therapy is key, but how do you get health workers to provide, healthcare providers to buy into it? Okay, I'll give my thoughts and I'll ask I think Dr. Kate Kerr had some other commitments and has had to leave, but we have Dr. Teresa and Dr. Adolfina with us. So I think, there's no one simple answer to this. I think it's all a matter of advocacy and pressure coming from data and appeal. So the data is that without regular replacement, there is no alteration of the natural history of hemophilia. That's the core message, the most important message of the third edition of the guidelines. And there's no way you can do regular replacement unless you provide home therapy in the long run, effectively for a large section of the population. So the message that without regular replacement, it's almost as good as not treating hemophilia is the most important message. You need to then build that up in a way that is practical for the healthcare providers, Ministry of Health, to accommodate within the budget they have. And so low dose prophylaxis is a good starting point, and then enhancing the dosage till it reaches a level where the child, the adult can perform their functions, lead their life without any bleeding if possible, but certainly with minimal bleeding. So that's the general concept. I don't know whether Dr. Teresa or Dr. Adolfina want to add anything to that. Please feel free to.
Thank you,
Yeah,
Dr. Alok.
go ahead.
Yo podría,
We will have
Okay,
Dr. Teresa first and then Dr.
Okay, that's-
Adolfina. Thank you. Thank you.
All right. What I will have to add in addition to what you said is that home therapy is something that has to be done with the person with hemophilia and their caregiver, and the treater. It's like they need to do it together. It's not a directive that comes from the treater to the person with hemophilia, because you have to get their confidence to be able to know and comply with your instructions when they get home, that this is how they're going to use the product. And I totally agree with what you said, that there is need for us to get on top of hemophilia bleeds. There is need for us to constantly replace this product when needed. And we cannot achieve that without home therapy, especially for our patients that have to come from quite a distance to the hospital. And by the time they're able to do that, a lot of damage has already been done to the joints. So it's something that the caregivers, persons with hemophilia, need to work hand in hand together with the treaters. Thank you.
Thank you. Thank you. Dr. Adolfina? You may need to unmute.
no, it's okay.
Dr. Adolfina mentioned, and I'll try to summarize what she mentioned. The Mexican Institute of Social Security started around 15 years ago to provide treatment to patients. And at first, in one hospital, they started to do home delivery. Before this, when they wanted to do home therapy, the patient or the first or one of the family members had to be trained in self infusion, all the requirements for the self infusion, and then when they pass, let's say a test or an exam by the nurse, they would get certified and they could start receiving the treatment. So we could ensure that they properly knew how to use the product and how to keep the safety measures. Then in one hospital, the home delivery started as a sort of pilot, but that had continued, and that segmented the care for the patients. Now, thankfully, almost all the hospitals in the country have home delivery. So it doesn't matter where the patient lives, they can receive monthly the dosage that the doctor specifies for them. Most of them are in prophylaxis. So many of these patients can destinate or use their time, instead of going to the hospital, to take care of themselves, to take care of their joints, and use the treatment provided by the doctor. So we could say that there's a big experience on this matter. But the first part was to train and educate the patients, and even some patients with inhibitors are receiving this home care, home delivered care. But again, this has been a 15-year work. Thank you.
Thank you so much. So we've taken more than 5 or 6 minutes to answer that one question, but it was a very important question, very important points made by the panelists. Apart from having the scientific recommendation and advocacy, obviously there needs to be government commitment and training of the healthcare giver to administer the products. We will go a little faster with the rest of the questions. There's a rhetorical question from Dr. Hani Ayaz. I wonder how many countries have hemophilia comprehensive care centers? Well, we don't have a full answer to that question, but the important thing is that every country should at least have one, maybe more, comprehensive care centers, which can then provide the training hub for getting more centers going for people with hemophilia. Dr. Tahira had asked a question about how do you go about getting support for factor concentrates. What's been our experience in India? Well, we've been at this for more than 25 years, Dr. Tahira, and in the last 10 years, there has been remarkable success, predominantly related to the political class here realizing that healthcare earns them more support in the elections. So once healthcare becomes a focus in for support for the political masters of the country, it then starts getting more attention. What we managed to do is to get hemophilia as a line item in the healthcare budgets of the state governments that manage the therapeutic healthcare in the country. So it's basically advocacy, the economy in the country, the political class understanding and accepting that providing healthcare is important and allocating the necessary budget. We also, of course, need to get enough suppliers to come into the country, provide competitive rates for these products, and then we have a much improved situation compared to where we were 10 years ago. The next question is from Dr. Sergio Luis Gustavo about the third edition of the Hemophilia Guidelines. Chapters 1 and 2 could be a guide for the development of the program. Yes, indeed, it is not only meant as a guide for physicians and healthcare providers, but it's also a guide for advocacy organizations on how to go about garnering support from the ministries of health for establishing care. Okay, is liver transplantation a cure for hemophilia patients? The answer is yes. Liver transplantation can be a cure, but liver transplantation is only offered to people who land up with liver failure, usually related to chronic hepatitis, or in some cases, if people have had a liver malignancy for which they were treated with liver transplantation. So it's not something that is offered because it's a complex and a high-risk procedure. It's not something that's offered to people with hemophilia with otherwise normal liver function. Okay, there is a question from Dr. Haniayas to Dr. Tessie. In Nigeria, what percentage of hemophilia A and B? How many have infectious viral diseases? What is the management for them? Are you doing screening, genetic tests for female carriers? So Dr. Tessie, for you, please.
Oh, okay. Thank you for that question. In Nigeria, majority of our patients have hemophilia A, and that will put it at about 85 to 90% of the patients we see have hemophilia A. About the screening, we do the screening per hemophilia treatment center. Those are the baseline investigations that we do for any patient with hemophilia visiting the center. Is there any, sorry, I didn't get the last two questions.
Okay, so yeah, they talked about, what percent of people have infectious viral diseases and what management for them. A short reply, please.
Oh, okay. I'll say from my own center, we've just had about 2 patients that have tested positive to screening of hepatitis C. And there is what we just did was to refer them to the gastroenterologist. So they are receiving care from the gastroenterologist. And
is anti-hepatitis C treatment available to patients in your
Nigeria?
country?
Yes, it is available, but it's quite expensive. It is available, but it's very expensive. So the gastroenterologist
I have to mention that through arrangements made in India and Egypt, but a lot in India with Gilead, the 3-month therapy is less than $500. So I think maybe the NMO, the hospitals need to think about getting access to fairly cost-efficient hepatitis C therapy that's now available legally through arrangements made with Gilead. Okay, a question from. Okay. Yes, Tessie, go ahead. You wanted to make any final comments?
Yes, I think there was the last question I wanted to comment. There was the last question he asked I wanted to comment on.
Go ahead.
I
Go
was
ahead,
hoping to
please.
get that from you, but
Yeah,
there was
go
the
ahead.
last
Go ahead.
question. Yes, he commented on, and I don't have the question, but I think you can go on. He mentioned 4 questions. I was able to answer 3, but go on, Dr. Alok.
It was about genetic testing for carriers.
Oh, okay, that's fine. Currently, we do not do that. We don't have genetic counselors in Nigeria, and we are trying to build capacity for genetic counselors, and we do not do genetic testing for our female carriers. Thank you.
You did mention that in your slide, yes. So this is a question from Dr. Sergio Gustavo. In Nicaragua, we have a similar situation like Nigeria. We have trouble, many patients resistance to move from plasma and cryo. Okay, this is more a statement than a question. We will let that go. Dr. Imran from has asked, it's not a question, rather it's a request, feedback. Here in Pakistan, main problems we face diverse. First, I'd like to highlight there are few centers for a population more than 220 million, not enough centers, not enough concentrates, and blood banks are not able to provide enough controlled products, plasma or cryoprecipitate. A lot of physicians and pediatricians in far off areas, but no minimal experience with bleeding disorder. So yeah, we recognize, Dr. Imran. I guess, there's obviously need for more training and more products. I think Dr. Tahira's question was similar. Finally, it boils down to advocacy with the government. That's the final step in really getting comprehensive care going in any country. Organizations like the WFH provide the training, the support, but finally it has to happen at the country level. Question to Dr. Adolfina. In Mexico, this is from Dr. Hani Ayash. Have you tested hemophilic patients only for coagulation tests? Do you do systemic tests, blood counts, liver tests? So in a person with hemophilia who comes, a suspected hemophilia who comes in, do you only perform the coagulation assays, or do you do other blood tests, blood counts, liver tests? Dr. Adolfina, short answer, please. Thank you.
Translate, please. Translate to Spanish, please.
Basically, there's systematic testing, both for coagulation, for inhibitors, and for virology. So we have find that there's a very low incidence of inhibitor, of high response inhibitors, less than 11%. There's also testing for HIV and Hep C virus. Thankfully, there's Hep C treatment now, so a lot of patients are receiving this treatment for the eradication of the virus, and less than 3% of the whole hemophilia population in the Social Security Institute have less than 3% of the hemophilia patients are HIV positive.
Okay, thank you. Look, we have tried to answer as many questions as we could. We've extended the time almost 15 minutes. I'm under instruction now to try and wrap this up. And what I can assure you is that we will keep these questions and send you replies by email. Let me just conclude this webinar by thanking at least 140 plus participants from many countries who shared their time with us today to listen to the description of the principles of care that has been outlined in the latest third edition of the World Federation of Hemophilia Guidelines for Management of Hemophilia. Dr. Kate Kerr provided a detailed description of comprehensive care, how it should be established, and some of her experience from UK, which was then followed by a description by Dr. Tessie Nuvaga from Nigeria and Dr. Adolfina Garcia from Mexico of how comprehensive care has evolved in their countries. The core messages being that it's important to understand what we're trying to do, what the scope of it is, to gain knowledge, and then build slowly, to persevere, to be passionate about what one's trying to do. There is no one perfect solution for all situations. We have to individualize and accommodate the conditions that prevail in the country, knowing clearly where we want to be ultimately. Getting products for treatment, starting their use in prophylaxis, in regular replacement, looking at outcomes and reporting those outcomes will also be very important. So with that, I'd like to thank all the speakers. I'd like to thank all the participants, and of course, the World Federation of Hemophilia for taking this initiative to create a very unique program. This has not been an easy webinar. You know, we have translations in 4 languages. We have speakers in at least 2 languages, and translations live during the discussion. This has been a most interesting session. I thank everybody who took part in the program and hope that we will see more of you in the next 2 webinars in this series. Thank you and goodbye.